Now, ventricular fibrillation, as I said, ventricular tachycardia, as that patient, if they have hemodynamic collapse, the myocardium begins to suffer and become more irritable. It can go into ventricular fibrillation. And ventricular fibrillation is the most common rhythm associated with sudden death. So when you hear about patients falling out in Walmart parking lot and needing CPR, it's almost always because they have gone into the rhythm of ventricular fibrillation. Now, there's obviously something else that caused them to do that, whether they were having an MI or whatever, but ventricular fibrillation tends to be the thing that is going to cause these patients to have sudden cardiac death. And what ventricular fibrillation is, well, if you think back to atrial fibrillation, basically that atria is just sitting there quivering because we have multiple ectopic foci now in the ventricles, all fighting for control to be the dominant pacemaker, but nobody here's winning. And so we end up having an uncoordinated contraction, if you can even call it that, of the ventricles. Now, what happens when the ventricles are not contracting normally? Well, the heart cannot even perfuse itself, so we have no myocardial perfusion. And if you've got no myocardial perfusion, well, that's not good on the myocardium at all. It becomes acidotic, and it becomes even harder to get these patients out of this rhythm. And if there's no coordinated ventricular contraction, the patient also isn't going to have any systemic perfusion, which means immediately upon ventricular fibrillation, this patient is not going to have a pulse. If a patient has a pulse and you see something that looks like ventricular fibrillation on the monitor, it's not. These patients do not have cardiac output. They will not have a pulse. And if you don't have a pulse, you don't have a blood pressure. These patients need emergent and immediate defibrillation. And that's why anymore you hear about AEDs being placed throughout the community. This is automatic external defibrillators. These are ways that lay people can get electricity to these patients as fast as possible. The sooner that we can get these patients defibrillated, the sooner we can restore the normal rhythm, the higher the chance of us actually converting them out of it and them surviving. So emergent defibrillation for ventricular fibrillation. Characteristics of VFib. So what is it? Basically, if you think back to atrial fibrillation where the atria is just quivering and there's this, the baseline is not isoelectric, there's constant movement. Well, we're having the same thing now, but it's coming strictly from the ventricles. It's total chaos. And it's simply as if I gave my 6-year-old a piece of paper and a pencil and just had him scribble. Those waveforms are of different size and different duration. There's no regularity to it whatsoever. It's just complete and utter chaos as that ventricle is just quivering like your grandmother's legs on a cold day. The rate's going to be really, really fast, if you can even measure it out at all, somewhere between 150 to 500 quivers a minute. Now, here is a rare 12-lead EKG of ventricular fibrillation. Why would this be rare? Well, these patients don't have a pulse. We would be more concerned with giving them an electric shock than we would be putting 10 electrodes over their body and connecting wires to record a 12-lead EKG. So, yes, it looks like to me, maybe at the beginning here, the patient had some type of organized rhythm, and we happened to catch it as they went into ventricular fibrillation. Now, we would want to look, if we can, at the rhythm strip across the bottom in order to kind of get a good idea of what's going on here. And we see constant quivering and motion. It is completely irregular, no chaos, no organization whatsoever, and that's ventricular fibrillation. So causes of VFib, these patients have some health problems, and usually they're going to have some history of coronary artery disease in a previous MI. It's also very possible that this is kind of the tail end of them having an MI. They had an occlusion of a coronary artery, the myocardium began to suffer, and it suffered so much that it became hyper-irritable, and the patient went into VFib. They've either got some kind of structural heart disease, something is going on with these patients. This does not happen to healthy individuals. Long QT syndrome, and we'll talk a little bit more about the QT interval in a minute, but long QT syndrome can be responsible for VFib and also electrolyte abnormalities. Typically, when we think about the electrolytes associated with cardiac rhythms, we're talking about potassium, calcium, and magnesium. You want to look for reversible causes, the H's and T's. This is listed in your book. So make sure you look over those. H's would be things like hypoxia. T's would be things like a thrombosis. It's just a good, easy memory tool in order to learn the different causes that we could potentially reverse or deal with to make these patients better and help them to recover. So treatment for ventricular fibrillation, once again, is immediate defibrillation. And we can give these medications such as epinephrine, amiodarone, lidocaine, and magnesium. There's not a lot of data out there that supports their use that really says they're very beneficial. But in theory, these are things that we would hope to work and have continued to be used in practice. And so as you later on, I think next semester, you'll be talking about ACLS. Really, that's going to be the guidelines that you'll follow for the treatment of ventricular fibrillation. All right, moving on. So this one is called torsades de pointes. It means twisting of the points in French, and that's exactly what's happening with this rhythm. Now, we've talked about monomorphic ventricular tachycardia, where all of the QRS complexes are going to be identical, right? Well, this is a polymorphic ventricular tachycardia. So each of the PVCs, so to speak, are going to have a different appearance. And that's because they're coming from a different focus and there's a different axis of depolarization that's occurring. Now, it's a polymorphic ventricular tachycardia, but to be called torsades, the polymorphic ventricular tachycardia has to be caused by a prolonged QT interval. If it doesn't have a prolonged QT interval before it occurs, then it simply goes by the name polymorphic ventricular tachycardia. That's a mouthful. All right, let's take a look at this rhythm strip down below and see why it's called twisting of the points. Now, if you were to take a look at this closely, you would see that the pointier part of the QRS complex starts out down here at the bottom. But as we move along, it switches or twists up to the top part of that rhythm strip before it eventually twists back down to the bottom. So we have a twisting of the points. And this is because there's a change in the direction of the flow of the depolarization and the change in the amplitude. Now, the change in the amplitude can be seen better as we look at these tall amplitude, followed by short, followed by a tall, short, and tall again. And if you've ever read Dubin's textbook, he describes this as appearance of a twisted party streamer. So you imagine those ribbons that are kind of twisted, that's what this looks a lot like. So that's torsades de pointes. It's going to be an irregular rhythm because it's polymorphic, and those R-to-R intervals should not march out. And the rate's going to be very fast. We're going to see that it's somewhere between 150 and 250 beats per minute. And we'll see the twisting of the points, the change in the height of the QRS complex, and that's because it's changing in its axis and amplitude. Now, that example right here is very blatantly big and small, big and small. Sometimes it's not quite so apparent, like the example down below, but you can still see that there is some motion in that rhythm strip. Now, again, for it to be called torsades, it has to be a polymorphic ventricular tachycardia caused by QT prolongation. So here is a 12 lead of torsades. And the cool thing is that we've actually got, before we get to the torsades, some sinus beats over here. And we know it's sinus because we look at leads 1 and 2 and we see the upright P wave. And the one P wave that we do have in AVR, we can see that it's inverted. So this meets our criteria for a rhythm beginning in the SA node. The other cool thing is we can actually look to see that this patient has a prolonged QT interval. Now, wait a minute, you probably have to go way back to one of those early chapters where we talked about what the QT interval was and how we measure whether or not it's prolonged. So the QT interval is the beginning of the QRS complex all the way to the end of the T wave or the end of the U wave if there's one attached. Now, roughly speaking, we haven't gotten into the fine details of what the exact measurements are, but roughly speaking, if the QT interval is 50% or more of your R to R interval, then it's prolonged. And you can just see, even by looking at the number of EKGs that you have, that this ST segment looks awfully long there. So the patient has a prolonged QT interval before they go into this polymorphic ventricular tachycardia. And again, if we want to look at the amplitude, we need to be careful not to look at these leads where things cross over and they're going to give us a different perspective. Ideally, we'd like to see this in one lead where it's continuous. So we want to look down here at lead 2 and we can see the amplitude changes like that. And again, the reason you don't want to look at the amplitude here is because it's looking from a different perspective, and so the change in the amplitude is not because it's necessarily twisting in the points or changing in the axis. It's because it's coming from a different perspective, right? So we want to look at a single lead to evaluate this when at all possible. Now, the other thing about torsades we haven't mentioned yet is that it's usually self-limited. So as you can see in this EKG as well, the final couple beats over here are also sinus. So this patient has a short run of torsades and then it's self-limited and the patient converts back into a sinus rhythm. So that's kind of classic of torsades. It's usually self-limited. Now again, if I haven't said it enough already, it's due to a prolonged QT interval. Now this can happen from a couple of different things. It can be congenital, and maybe they were born with just a prolonged QT interval. There is a thing called congenital prolonged QT. But it can also be things that we give the patient, like medications, or some problems with their electrolytes. So I put these in the category of what we call anti and hypo, just because it's a good way of kind of remembering the things that go in the category. So anti-arrhythmics, antifungals, and antibiotics. And then you also have hypokalemia, hypocalcemia, and hypomagnesemia. Remember earlier I had said that the electrolytes that we often see associated with these rhythms are potassium, calcium, and magnesium. So if you've ever prescribed somebody antibiotics for a pneumonia or urinary tract infection, and they say, hey, by the way, oops, this will go down here. By the way, after I take these antibiotics, I get a yeast infection. Can I have some diflucan? And so what you would end up seeing maybe when you prescribe those two medications together is that your electronic medical records will say, warning, warning, you know. It's because the combination of these two medications can prolong the QT interval. Now, most of the time I'll go ahead and do that if we need to, but it's always something to be aware of. I mean, when we put these medications together, if you've already got somebody maybe who is on an antipsychotic even, and you put them on these different medications, now we've just really combined and we can really stretch that out and it potentially cause some problems for the patient. So prolonged QT interval is torsades to points. Those two go together. Now, if the patient remains in the rhythm, again, it can be self-limited, but if they remain in the rhythm and they're unstable, the thing we always do when they have a pulse but they're unstable is electrical cardioversion, okay? And again, we should put the name synchronized over here too, and that means we want to hit that electrical shock right over the top of the R wave so we don't cause a worse rhythm to occur. Now, if they don't have a pulse, you got it, defibrillation. Now, one thing to keep in mind is magnesium. Magnesium and QT, these things are all kind of buzzwords when it comes to torsades to points, magnesium, QT. Magnesium is the medication that we give to these patients with torsades. Now, even if their magnesium level is completely normal, yes, a low magnesium can cause a prolongation of the QT and make them more prone to that. But even if their magnesium level is normal, we can still give IV magnesium as a first-line treatment and prevention. So very important to remember magnesium and torsades to points. Another treatment we can employ is overdrive pacing. And this is actually where we connect the patient to a pacemaker and we crank up the rate faster than the torsades, capture the myocardium with the pacemaker, and then we begin to turn the rate down so we can dial them back and kind of take control by overdrive pacing that patient. So that's another way you can do it. All right, that's torsades. I think we just have a couple more rhythms here to go. Ventricular escape rhythm. Now, everything we've talked about up to this point has been a rhythm that kicks into gear because things are really irritable. It's going much faster than it's supposed to. But this, when we talk about escape rhythms, we're talking about the backup system of the heart, the thing that we want to be working to kind of keep us alive when other things are failing. So let's kind of go through that for just a minute, and I'll refresh your memory when we talked about this. So obviously, the right normal pacemaker of the heart is the SA node. Now, it has an inherent rate, depending on what resource you look at, somewhere between 60 and 100 beats per minute. But we know that the SA node is not always going to work. Sometimes it's going to fail on us. And so the very next thing that God established is an atrial ectopic pacemaker that can be somewhere in the atria that would take over pacing. And as the further we get down in the system, the slower the rate. And so we have a downward displacement of the pacemaker. Maybe if the SA node's not working now, we're relying on an atrial ectopic focus. Well, if the atrial ectopic focus decides not to work, then we have to rely upon the next thing in line, and that's the AV node. And we know that the AV node is going to have a slower inherent rate, somewhere between 60 and 80 beats per minute. And that's because we want to give that an opportunity to kind of kick in. Actually, I was wrong about that. It's getting late, y'all. 40 to 60 beats per minute. That's more like what we're talking about with the AV node. So the AV node is going to be waiting on the atria. If that's not going to work, then we have to keep on moving down the system. And so what we end up getting here is now at our last ditch effort, we have run out of everything up here, and now we are simply down to an ectopic focus somewhere in the ventricles now that has to pace the heart. This ectopic focus down here is somewhere between 20 and 40 beats per minute. It's because it was very patient. It waited on everything else. And so it tries to wait. It tries to hold off on doing anything. It doesn't want to take over unnecessarily. But now everything else has left it, is banding the ventricles, and they have to pace on their own. So the rate here is typically going to be very slow. And so what we have with the characteristics of a ventricular escape rhythm is a regular rhythm. If we were to march it out, those R to R's would be nice and regular. We would have a wide QRS. That tells us it's coming from the ventricles. The rate is very slow, oftentimes in that inherent rate that we expect, although not always perfect. And there are no P waves. That's because there's no atrial depolarization occurring. Now, if you were to think about it, is there another rhythm we talked about that can look very similar to this one? So if you said a junctional rhythm, you would be right. Now, let's refresh on the junctional rhythm. There are 3 different appearances a junctional rhythm can have. Now, looking at lead 2, we could see an inverted P wave just before the QRS complex. We could have an inverted P wave immediately after. Or, the one that's most similar to what we're seeing here, there would be no P wave at all. And so how would we know the difference between a junctional escape rhythm with no P wave and a ventricular escape rhythm? Well, hopefully you said because it's a wide QRS. If you'll remember, the AV junction up here is going to travel normally down through the His-Purkinje system, and we're going to have a narrow QRS complex. But because this ventricular escape rhythm is coming from the ventricles, we're going to have a wide QRS complex. So even though the rate may be somewhat helpful because they do have different inherent rates, it's not a perfect solution to look at that. So your most helpful identifying feature there is going to be to measure the width of the QRS complex. Here's a 12 lead of the ventricular escape rhythm, and as I've always kind of pointed out, if you just look at this 12 lead, you can already see that things are very slow. You don't even have to calculate the rate to know this thing is way down there. I'm guessing just by looking at it, and I haven't measured it yet, believe it or not, probably 20 to 30 beats per minute. So very slow. It's definitely within that rate of the ventricular escape rhythm. And if we were to measure this thing out, we would see that the R to R's, what few that we have on here, are indeed regular. And then if we take a closer inspection at the QRS complex, we'd see that it's wide and there's no P waves. So we have the criteria that fit a ventricular escape rhythm. All right, I think there's one more. Oh, well, we got to talk about symptoms first. So symptoms of ventricular escape rhythm, just like most rhythms, are going to depend on just how slow the rate is and what kind of health condition the patient's in. Now, because this is a rhythm that we see when everything else has failed, usually these patients are pretty dang sick. And so if the rate is slow at all, they're going to have some hemodynamic compromise. We're decreasing our cardiac output. And if you go back to the old thing, heart rate times what we call stroke volume equals cardiac output. So we've got plenty of time for the ventricles to fill. The stroke volume is going to be good, but that heart rate is way low, and so our cardiac output goes down too. So this one, I guess we could draw an up arrow. So stroke volume is good, but heart rate goes down, and so our cardiac output goes down. So they're going to have some hemodynamic compromise. Patients who have a decrease in cardiac output, well, they're going to complain of dizziness, shortness of breath, and chest pain, and we'll see their blood pressure drop because of that decrease in cardiac output. So how do we treat this? Well, just like all the rhythms that we've talked about that are slow, we're going to give these patients atropine. And you can repeat atropine every 3 to 5 minutes up to a total dose of 3 milligrams. So that would be 6 potential doses you could give of atropine. So if you can do that, that's great. Now, another option would be to pace these patients, and you can use a transvenous pacemaker or a transcutaneous pacemaker. A transvenous pacemaker is something that has to be placed by somebody with some specialized training in it. So you're looking to have a cardiologist on hand or one of your ER providers who knows how to put in a transvenous pacemaker. This isn't something you just walk up and you can do. So there's some expertise required in that. Now, transcutaneous pacemaker, well, anybody can hook that up. Basically, those are the defibrillation pads stuck on the patient's chest. Now, the problem with transcutaneous pacing is, I want you to imagine for a minute, having some defibrillation pads put on your chest, and for every time your heart beats, we have to send an electrical current through your chest into the heart. It's uncomfortable. These patients usually don't like it, and so you have to be able to consider whether or not you want to give that patient sedation. And the thing with most methods of sedation is it's going to decrease the blood pressure, and we're already talking about a patient with decreased cardiac output and likely who's hypotensive, and so trying to manage that situation can be a bit tricky. So, but these are options that we have. Now, after we've given atropine, we've run out of our doses of atropine. Maybe we don't have a cardiologist or ER provider on hand who can do a transvenous pacemaker. Transcutaneous pacing just doesn't seem like a very viable option. One of the things we can do is start the patient on a dopamine or epinephrine drip, and that will help to keep the heart rate up, and it will be at a constant infusion so that we can keep that heart rate up at all times. Last but not least, accelerated idioventricular rhythm, okay? So this is really essentially a lot like a ventricular escape rhythm, but the rate for this falls in the category that's really too fast to be an escape rhythm and too slow to be a ventricular tachycardia. So we're looking at the neighborhood here in the rate 50 to 100, 60 to 100 beats per minute. Now, we see accelerated idioventricular rhythm almost always as a sign of reperfusion after an MI. So imagine, if you will, a patient who has had a heart attack. They've got an acute coronary occlusion. Because that myocardium isn't getting the blood supply, it's suffering. And they get rushed off to the cath lab. The cardiologist opens the artery up. Now they've got an inrush of blood flow to the myocardium, probably more than they had even before the MI, because now they've got things wide open and they're getting all that they need. And these patients will tend to go into AIVR. It's just a sign of reperfusion. The good news is there's no danger to it. The rate is quick enough that the patient's cardiac output's good. It's not so fast that they're having issues. And this rhythm is self-limited. It doesn't last forever, maybe a few hours, and really no more than 24 hours this AIVR will be present. So it looks a heck of a lot like a ventricular escape rhythm. It's nice and regular. The QRS is going to be wide because it's coming from an ectopic ventricular focus. There's no atrial depolarization, so we don't have any P waves. And again, that ventricular rate is going to fall somewhere between that of an escape rhythm and tachycardia. So somewhere around 60 to 100 beats per minute. And the other thing to keep in mind is it's self-limiting, and there's really no harm to this rhythm whatsoever. So what you can see here on this 12 lead, and I'll give you a minute, and maybe good to even pause it and kind of inspect it before we go over it, and then you can start it up again. But really here at the beginning, what we see are some sinus beats at the very beginning, some additional sinus beats here, and that's because we see the P wave in the narrow QRS complex, the upright P wave in 1 and 2, and we don't see the P waves here because in this area we have gone into the AIVR. Okay, so it's a nice regular rhythm. the absence of P waves, the QRS is wide, and the rate does not fit that of a ventricular escape rhythm or tachycardia. So the other thing I want to point out while we're on this slide is the presence of the ST wave discordance. Now, think back to when we talked about PVCs at the beginning of this lecture. Anytime you've got this ventricular ectopy, you'll have ST wave discordance appear. So with these very tall R waves that we have over here in the left-sided chest leads, what we would expect to see then is the opposite happen with the ST segment and the T wave. So we do see a little bit of ST depression, and then we also see the inverted T wave here, and that's the ST wave discordance. So again, important to be able to identify that so you don't look at this and think, man, this guy just got back from the cath lab and he's having another ischemic event because he's got ST depression. And this is a normal finding, ST wave discordance. Here's one more, and the very last 12 lead of the whole lecture. It is another rhythm of AIVR, another 12 lead of AIVR. So again, we're looking at the rate, and we see that the rate is faster than it should be for an escape rhythm and slower than it would be for a tachycardia. We've got a nice regular rhythm. We've got a wide QRS complex. There are no P waves to be found, and so we have AIVR. And it's also helpful to know, because this happens after reperfusion, that the patient situation probably would be a very helpful thing to say, hey, this guy just got back from the cath lab 2 hours ago, and then you do this 12 lead. You kind of put it in context of that situation. So you finally have it. Sorry it's taken me so long. I think I've got this under wraps now, and so I can begin to start pumping out the next few lectures and maybe even get ahead a little bit so that you'll have opportunity to access this information well before we have review lectures and try to do some practice in class. So we'll see how this goes. Give me some feedback, and if you like the flipped classroom idea, I think it'll be useful, then let me know and we can keep pursuing that. Until next time, see ya.